can only be explained by meridian literature, because the colon and brain have to do with metals. But just to show how you can follow a patient's history around the chart like this. So coming back to our diagnostics, when you have mercury in your system, you can have it outside the cells or inside the cells. And then you have to remember, this can measure outside, and this has to measure also inside. I have no idea about the amount it would also measure extracellularly. But from the studies we performed in the clinic, I can just conclude that it is mainly an intracellular measurement, as shown here. Now we have a provocation test. You see almost no heavy metal, lead, you see, in a value 18, which is really nothing, 18 micrograms per gram. But the same patient, which has illness and is very sick, shows this heavy metal profile in the Oligoscan. Maximum or almost maximum oxidative stress with very high mercury. The mercury intracellularly very high, extracellularly almost non-present. How is that explainable? So when we saw one of these profiles, the doctor I worked with thought, we have another device which does nothing. But I just remembered that scheme what you saw with extra and intracellular, which is from a German physicist from the late 50s. His name is Reckeweg. Immediately I got the image of Dr. Reckeweg, because I knew at that time with the first patient, when we don't see it extracellularly and we see it here now intracellularly, we just have to follow the first 100 patients and see what will be coming out of that. So we did that. We did a provocation test with these chelating agents. We did an Oligoscan, and we found this correlation. So the higher the mercury is in the spectrophotometrical analysis, the lower it is excreted in the urine. And the higher it is in urine, the lower it is in the Oligoscan, which is all logic, because when it is present extracellularly, it is not present intercellularly. And when it is present inside your cells, it will not come out with even one of the most potent mercury binding products. And the Pearson correlation is extremely high. Statistics friends have told me, this is just ready for publication. And I said, yes, we already sent some, but it's difficult to get it accepted because they ask you for the method. And the method, of course, it is easy explainable provocation test, but the Oligoscan, how does that work? Nobody tells you. And because you cannot explain the method, they will not accept this kind of study. So the only thing we can do, I'm a pragmatic, I am really not interested in studies as well, I'm only interested in the benefit of patients. What I think what will happen is that very slowly around the world, some people will accept this method and will do their own research, and everybody who has already found something, that will all come together, and it will, in 5 to 10 years, will be accepted as something normal. And then major magazines will come back and ask for something to be publicized. But now it's very difficult because I cannot explain the method. Nobody tells me as well how the calculations are done. So this was especially found in people with high oxidative stress. So when you see a profile like this, high oxidative stress, when this is in the red, you almost invariably see a high mercury. That's the whole story from the beginning. Mercury causes mitochondrial dysfunction due to all these reasons with glutathione. Therefore, oxidative stress increases, and therefore the cell does not function anymore, and you cannot get rid of the metals. They stay intracellularly. So the conclusion from this study or observation that in patients with high oxidative stress, there is a very strong negative correlation between the Oligoscan and the provocation test regarding mercury. So a high mercury content in the Oligoscan correlates with high oxidative stress, which is very logical, as I explained this morning or this afternoon, of the relationship of sulfur and selenium. And in people with high oxidative stress and high mercury in the Oligoscan, chelation with even the most potent DMPS will show nothing of mercury. And in people, now it becomes interesting, people, how is it in people with normal oxidative stress? Can we predict if these people then have high mercury in the provocation test or not? Well, you cannot. That's the conclusion. You have to perform a test to see if they are metal loaded in the extracellular environment. Whether you do our kind of test or a test with DMSA or whatever you want to use, but you need another test to show or to prove if the patient has a problem with toxic metals. Because this is the profile of someone with very good oxidative stress. You will have many people here like that. Of course, we also see the aluminum signal that we have addressed, a very common metal in the surroundings. But how about the provocation test? Well, this patient eliminated much mercury, 56 is already high, and you see many more metals elevated. But you cannot predict, because you could also have patients with good oxidative stress and low metals here. And of course, those are the really healthy ones. Because when you don't eliminate extracellularly and you don't have anything intracellularly, then you are just blessed as a person. So, if you now still doubt the story regarding the Oligoscan, I have one more thing for you. I come back to this hair mineral analysis. This is a hair mineral analysis where we see at first a high potassium and iron. And I tell you, this is a Brazilian marathon runner. What proves that he is a marathon runner? That's the high sodium and iron. Why? He runs 40 kilometers each day, 2 days, and with their heels, they smash their red blood cells when they are running. And then when the red blood cell is kaput, destroyed, a lot of sodium and iron is released. And that's a constant high level in his blood, upper range, and that is just lost in hair. Very simple. So the method proves he is a marathon runner. But he was very concerned about his high calcium there, extremely high. And he did not use any calcium supplement or whatsoever. So, being concerned, he met someone else in Brazil, a French guy, and he performed an Oligoscan. And we just look at the calcium. Extremely low. So he was even more confused. Then I got the question, can you make any sense of this? And knowing my intra and extracellular story, and I had patients who had this kind of profile as well, we started an idea. And the idea was to show this is hair and this is spectrophotometry, this is extracellular, this is intracellular. How can we combine these two paradoxal facts? This is one of my own patients, was also very low calcium. But what is important in calcium metabolism in our body? Everybody will argue nutrition, yeah, sure. But what is very important to get the calcium inside your cell? One, of course, is vitamin D. So that would be sunlight. You can easily measure if it's enough, yes or no. But there is another thing which is very important, because you can have enough vitamin D in your body, but it doesn't mean that it works very well, because vitamin D has to work on the vitamin D receptor. And what appeared now in all of these patients with very low calcium, they are all, so far in our clinic, 6 of 6. I report here 5 of 5. The Germans have now proven a few cases, and it is in all of these cases that the patients have a genetic SNP of the vitamin D receptor. They call this a single nucleotide polymorphism. This patient even had all 3 related genes mutated, which means, and now can prove why it is, the risk for these patients are osteoporosis, cardiovascular disease, tumors, etc., which is logical because not of the low content of calcium inside the cells, but of the continuous high concentration extracellularly. The patient is just in lack of the receptor or has a dysfunctional receptor, and therefore it appears in hair and cannot be transported intracellularly. Knowing this, because I heard this morning the calcium paradox, this is the calcium paradox. You can check it now. Many laboratories can easily do it. It's about 80 euros, 8,000 yen maybe, or maybe here a little more expensive, I don't know, to check for the vitamin D receptor SNP. And knowing this, even if this were a lady with osteoporosis, would you give her high amounts of calcium? Yeah, if you want to kill her, then you give her high amounts of calcium. Calcium for these patients is toxic, and therefore you find always high amounts of calcium in blood in osteoporotic women, because they lack the capacity to transport it inside bone or inside their cells. So what you could do, you give high amounts of vitamin K2, because that is a substance which can bring extra of calcium, which is located outside the bones, more away from tissue. Vitamin K2 can liberate calcium from atherosclerotic plaques and can liberate it from cartilage tissue. You can give soy in some high concentrations, which has a somewhat potent effect for putting calcium inside the bones. Women in Indonesia have never seen a cow. They don't drink milk. It's my opinion, milk is for babies. Milk is not for adults, and also not if you bypass 2 or 3 years of age. Look at an elephant, they become very large and very strong without milk after the first 2 years. We humans, therefore, you see lower capacity of calcium in people who use high dairy products. Because the dairy product, it's a bad form of calcium. It immediately reacts with phytates from nutrition. It binds and you lose it right away in the end. But calcium from vegetables is highly absorbed and usable. And women in Indonesia, when they fall, they never break a bone. When our women in our country, we are the most dairy consuming population in the world, because we have more cows than per head of the population than any country in the world. We use the most milk of all people around the world. We have the highest incidence of osteoporosis. And then our general doctor says, well, you still did not drink enough milk. Good. So what can we read more from the scan? This is a typical profile. When you see this profile, I don't have to see the patient. I know this is metabolical syndrome, period. I don't know if you can see it well, but you see a gray bar and you see a colored bar. The gray one is the first measurement The colored one is a measurement thereafter. Can be the first, the second dose, etc. So this patient had a high calcium initially. Now it's normalized. He had a very low phosphorus initially. Now it's normalized. So some things have normalized, some things have not. But what can we read from that? We teach this in the complete school. We talk about that for 7 hours. But in short, high calcium is a sign of nitrosive stress. That's the inflammasome from the beginning. High calcium you saw there. Sign of nitrosive stress. Low phosphorus means your cell membrane function is compromised, because phosphor you need for phospholipids. But also your energy level can be compromised. ATP, the P is phosphorus. Silicon, it's connective tissue. I speak 45 minutes in the medical school only about silicon, one of most forgotten trace elements we have. Zinc in this patient. A high zinc, as in this, has nothing to do with an intoxication. Nothing. This patient did not take any zinc-related supplements. It's just a sign of chronic inflammation. Why? Because the SOD enzyme, which is highly zinc-dependent, the cytosolic one, it upregulates when you produce too much radicals. So therefore, your body retains more zinc. In this patient, not corrected yet. Later, I can look up many other data for you. Now we know we give 4 weeks of berberine. I come to that at the end of the lecture. But when you give 4 weeks of berberine, all zinc is normal. It normalizes very quickly. And the high zinc is a sign of non-alcoholic fatty liver degeneration. Therefore, metabolic syndrome. When you see a very low chromium, like here, and it is an obese patient, then he has insulin resistance. When you see that in a person who is absolutely not obese, then you can have to do with, and that's not complete, this list, but you can have post-traumatic stress syndrome, you can have very bad sleep, phased sleep, you can have people who are in the acute phase of stress, but it all comes down to a lower level of IGF-1, insulin growth factor 1. That's all chromium. And it goes too far to explain here, but I want to point out a very specific relationship of chromium and glutathione. And the relationship is that chromium is held inside your cells with exactly the same amino acids as you need to produce glutathione. So can you imagine too much radical stress, your glutathione is gone, that you also miss the same amino acids to contain the chromium inside your cells. Boron. This morning I did not see boron highlighted as an essential trace element, but it is. It is very much an essential trace element, and I call it the hormonal one, because boron is very necessary in steroid hormone metabolism. So when you see an elevation in this patient, it does not mean he is boron intoxicated. It means that his body accumulates the extra boron to improve steroid synthesis. Because the fatty tissue in an obese person who has metabolic syndrome, the fat cells are inflamed. They produce bad estrogens. And to counteract that, the body needs extra boron. That's what boron does. But boron has also influence as a neurotransmitter. It enhances adrenaline, for instance. It's all scientifically proven. So boron has more functions. But in this patient, always a sign of inflamed fatty tissue. I forgot here to highlight, but when you see cobalt, it went here to the left. here to the right, because I almost invariably give one course of activated B vitamins to the patient who is chronically ill. We have a special formula. We don't give B1 and B2, no. We give riboflavin 5-phosphate. It's active phosphate. We don't give B6, it's very bad to give B6 to sick people, in my opinion. But you give pyridoxal 5-phosphate. I don't give B12, I don't give cyanocobalamin, it's a toxin. You have to give methylcobalamin or adenosylcobalamin, which is the active B12. And when we give that, you also see after 6 weeks that cobalt increases. Invariably, because B12 is a cobalt-dependent enzyme or a vitamin. And therefore, you see in all our patients, when I have given the product, an increase in cobalt. Then we have iodine. Iodium means iodine. And iodine has, of course, not only a function for the thyroid function, but is also a natural antiseptic. And what I have observed, this is not clinically proven, it's an observation, that all patients with chronic mucous membrane problems have a very low iodine content. I think that most people here in this country will not have so low of an iodine content because of the fish consumption. We have many patients who are very deeply in the red. Lithium, also forgotten. It's a necessary trace element. It is a product for the bone marrow to produce white blood cells, lithium dependent. But lithium also has a very intrinsic relationship with vitamin B12. There are many patients with polyneuropathy who get B12 from their naturopath, and it still doesn't work. Why? The B12 is very high in blood, but it cannot appear inside the cells because for that process you need lithium. Lithium increases binding proteins for vitamin B12. And then selenium, of course, it's the antioxidant molecule or trace element, and it is very much involved with mercury. Here we see a comparison of the toxic metals. As again, gray, very high in the beginning. This patient responded well with a decrease of everything except mercury. And why? I will tell you. This was a lady who was a little short for her body weight. She was 167 and 127 kilograms, so very obese. But she had the most beautiful teeth, which were only crowns. And she had hypertension and a lot of other complaints. So I told her, well, we need to check in time with the biological dentist what is beneath your crowns, because I'm sure that it will be tons of amalgam, because they just put a crown over a little drilled filling, because it sticks well. No, I just did this all, it's 10,000 euro, and no, I will not change. Okay, I said, I will gently detox you, gently, but when the mercury does not come down, maybe you are more satisfied with the answer then. So everything went down. You see every metal almost invariably go down, except for the mercury, which even has increased a little bit, but that is just due to the mobilization we did with the specific algae we used in this concept. But when you see crowns, just be sure that in 95% of them, amalgam is situated below them. And what does antimony do? Well, it's a catalysator for making plastic. And when she was coming everywhere where she went, she had a liter of water with her, and always drinking and sweating and drinking. And she accumulated the antimony, because her body accumulates everything. And then you also accumulate other toxic metals. The barium is associated with the calcium, same periodic table. Cadmium is cancer, mercury is neurodegeneration or autoimmunity, etc. She had some improvement in her oxidative stress because the aggression decreased by 13% and her antioxidation increased by 13%. So in the beginning, she had a negative value for the good and the bad species. And here, at least, it is an equilibrium. But I told her, if you won't change the things in your mouth, there is no hope for true regeneration. It's absolutely impossible. The first signs of an intoxication are lack of energy, but also remember an affective disorder. How do people get up? How do they go to bed? How do they sleep, especially when they wake up many times during the night? How is the libido? That's not only lust for sex, but also the lust for life itself. It's a hormonal thing, hypothalamic. Women especially report a change in hair quality, which is a trace element condition. And people also report a changed sense of temperature. That's not a true sense. They have maybe low normal temperature, but the sensation, oh, I'm always cold, or I'm always so hot, that's the change they experience, which is also a hypothalamic disorder. Of course, easy muscle ache after a little bit exertion, headaches, or digestive disorders. And when you have already concentration or memory problems, then you are already far gone. So now back to our scheme. What do we do before we commence any treatment? We have had these 4 now. I call this the combination of intra and extracellular test. Then check the spine. In the beginning, I told you about posture. Now I will tell you my personal history. I was born as yellow as a canary bird. My mother had eclampsia, pregnancy intoxication. I was born too soon or too early. Had to be put in a UV or a blue light tube and etc. So I was sick as a young baby. I had always ear infections and chronic tonsillitis. I got antibiotics after antibiotics, so I developed a kind of colitis disease with a lot of food intolerances that, of course, triggered me to become a doctor because nobody could help me as a young boy. I always went to a doctor, and many times those horrific syringes, etc. So many problems in psychological regard there as well. So I had to find cures for myself, and when I turned 80, I went to medical school. When I was 14, I had so much acne because my gut probiotics were so disturbed that the bacteria were coming out of my skin. So a lot of issues there as well. And of course, I had the chronic stool problems. And when I already was a doctor and alternative medicine, I left behind the gluten, I left behind the casein, and everything went better and still better, but still not good. And then in 2001 or 2, a patient of mine reported me, who I knew well, oh, you should see Dr. Sikkes in The Hague, and she's an old lady, but she developed a technique for correcting the spine. I said, spine? Yeah, you just go there once, you will see. So I went to her, and now she passed away, 93 years old, and back then she was then maybe 78, 79, and she saw me, she did not know anything of me. She said, take your clothes off, sit there in your underpants, I will tell you what illness you have. And she felt, oh, you have a whiplash, and oh, you have some problems in your thoracic. Oh, and you have very severe colon problems. I said, that's true. Yeah, I know that's true. I know my field of discipline. And she was a little autistic. And she corrected me, and my lumbar too was so displaced in all 3 directions. It was not only rotated, translated, and capsized. She hammered it correctly. She used a plastic tool with this plastic hammer to get it into place. You feel that when it slides back, it's not like this, but you feel that the vertebra is moving. And she said, now wait 6 weeks. And yeah, she always exaggerated. And she said, you will be lost of all complaints. But when I still had 50% of complaints, it was really reduced by more than 40%. Only a very small amount of complaints has been left over, and I think mostly due my own diet, when I don't pay attention enough, that I have the problem. I just tell you this to let you know that you can do any kind of therapy for your patient. But when you don't put attention to someone with heart problems, when you have a lady or man who said, my heart has started racing, cardiologist, stress test, EKGs, 24-hour readings, etc., but nobody looks at thoracic vertebra 2, 3, and 4. Sometimes it's just a very simple dislocation there. If that is corrected, all problems are gone, all, regarding that complaint. Many people with chronic migraine are being treated with I don't know what. They just have